This is the exercise done in unit 3 last week, sir. This is 85-year-old male with intertrochanteric fracture of left femur, bowel gripping type 2, sir. This combination of lesser trochanter. We have done CRA with PFN, sir, for left femur. And this is a 50-year-old female with closed trimalar fracture subluxation of right angle, sir. This is a fracture of even posterior malleolar fracture is also there. This is supination external rotation type of injury. So first we have gone through posterolateral approach and fixed reduced lateral malleolus, and then fixed posterior malleolus through recon plating. Sir? Yes, sir. We have gone through posterior lateral approach, sir. Lateral only you heard. Sir. Yes, sir.
We do not know, inadvertently or purposefully, that reduction was done wherein the distal fragment was pushed medially, making the fragment to get impacted here. Just like the McMurray's osteotomy, if you know what is McMurray's osteotomy, medial displacement of the distal fragment will give much more stability. Even if the fixation is not so stable, then the chance of failure of implant were very, very less. And he has shown quite a good number of cases. And I think he has published also. That is the trend now. Post-op.
Any type of fracture or
Only. Not so like a 4-part fracture. See here, it's very small fragment. Neck is not much there. If you make at least 5 mm of medial displacement, willfully, it is going to make it more stable. That is the present understanding. He has done quite a good number of cases. He has presented in one of the conferences. I have seen. So you can try that. And also, see here, why this screw, so-called Calcar screw, has gone more proximal. This should have been a little lower down. The plate is now gone above the greater tuberosity. Okay.
That's what so many people are doing, so many surgeries, all going into complications. I've seen many. Implant failure or infection deficit is there. Unless you do perfectly, which the mechanics is restored back, it's only the problem with that. But can you compare the upper end of humerus with the upper end of femur regarding the vascular supply? Vascular supply of upper end of femur, vascular supply upper end of humerus. Both are same or something different is there, which is important to surgical point of view? Did you read about blood supply to femur? You know, everyone knows it. But what about the humerus? Blood supply should be also be taught again for this. That's the reason I said arcuate artery is important here on the medial side. The blood supply, which is intraocular, which is extraocular fracture compared to hip in shoulder. Can you compare this with the femur, upper end of femur? fractures. Now, do you call this extraarticular or intraarticular fracture?
Extraarticular.
Extraarticular. Intraarticular? That should be anatomical fracture, intraarticular, compared to this both. So that should be always seen. Main thing is blood supply is important here. Unless you know properly, you will be disturbing the artery, then the problem of AVN comes here. Right.
Surgical. Deltopectoral process.
Staples वाला.
Long incision. Subdeltoid approach. It will be only up to here. What is the important precaution that you take when you are doing a deltoid splitting approach? What is the
Excellent.
important precaution that you take in a deltoid splitting approach?
Axillary nerve.
Simply
8 to
telling
10
axillary nerve is not an answer. You have to make a sentence and convey some meaning out of that. This is what is happening in the clinical presentation also, case presentation. They just say one word and leave it. Huh? We have to fill up the blanks.
Above the
Let him tell, let him tell, let him tell. Give some scope to him to
Plates.
speak. Yeah.
8 centimeters
8.
below the acromion.
5 to 7.
5
Below the
acromion.
acromion. Oh. Acromion is here. Huh? Greater tuberosity. Axillary null will be here.
What I am saying, blood supply, if you learn, both you can easily learn, along with the nerve, artery is there. You can completely see the surgical neck surrounding that, that's the area you can see it.
How do
So
you
always
avoid injury to the axillary nerve?
Splitting it or complete it.
You want to
Through.
dissect it out and see and retract it and then put the plate underneath that? Who has assisted this?
Yes.
Chepmari,
You should have
What?
known all these things.
did you see the nerve? No.
You didn't
No.
get a doubt
No.
regarding how to prevent
To avoid
injury
that
to
now.
that is the whole
Yes.
crux of the surgery. Otherwise, post-operatively, we
We'll get.
land in a deltoid paralysis. How to avoid injury? Sushma. No answer. You have to take a blunt bristow. Okay? Gently pass the bristow. It's a blunt, not sharp one. Okay? Abutting the lateral cortex of the proximal humerus, which will try to displace the axillary nerve.
As and when you come across an artery or a vein, be careful there is some nerve there. That should be an ideal always. Right. Yeah.
Okay.
Right.
Next. Okay, it has become a very mechanical job to
అదే
do
చెప్తున్నా
fixation.
కదా.
50 years.
Simply a mechanical job.
Now they are used to that only. Any case, either camera or plate or nail.
And we do not know, as you said, how many complications
Yes,
are
yes.
there in all the
Yeah.
pillows
50 years
there,
male with-
because we don't get the follow-up feedback.
3 years male with closed medial malleus fracture of left ankle, sir. Log-Hansen and pronation abduction type, sir. We have done open reduction.
Go back.
Is displaced or undisplaced?
Luckily, you have done the Martis view.
Hmm.
In AP and lateral
I
view,
think, yeah.
this fracture could have been very
Missed.
easily missed.
Yes,
It is
apply.
detectable. From here, it is
Not
not
yes,
so
not so.
clear. Of course,
But
by close observation, probably you will be able to. It could be easily missed.
yeah.
Yes.
Is it, we can get isolated medial malleus fractures commonly?
Rare, sir. Rare, sir.
any other ligament is gone here, how to make out this? Simple fracture will not be, definitely ligament will be there. Ligament on the lateral side, there should be tethering or there should be stretching of that. Simple fracture of, medial malleus will not get. Always be careful and see other ligaments which are intact or not.
Especially the anterior talofibular sorry, interosseous ligament.
All things, yeah.
Anterior tibiofibular ligament is the one. Usually that is affected. If necessary, you may have to take stress use
Yes.
to see whether there is any widening.
Lateral also.
Also, the overlap in the AP view, the overlap is the
Seen,
AP
sir.
view, the overlap of the fibula on the lateral margin of the distal tibia
Should be
is about 5 to 6
less than now.
This
Less
is
than
not
that.
Through AP view.
Why did you think of doing a just cast and leave it? We had some problem.
Yes.
Putting a short leg cast is not enough.
No, sir.
So what?
Medial malleus periosteal interposition may lead to non-union.
That's the only thing.
Yes.
Right.
Very likely.
Did you find during surgery now was the periosteum inside?
Yes, sir.
Invagination.
Yes, sir.
Right?
Yes.
You have seen.
Seen, sir.
Right.
Fixed with malleolar
Right.
screws.
Next, why not tension band?
Screwing is easy done.
What is the indication for the tension band?
Uh,
Or a fragment is small, they can do it, otherwise no. That should be the answer, right?
Very sometimes it can avulse only up to here.
Yes.
When you try to put drill holes, the
It may
fracture
split.
get splintered
Split.
and it cannot have a stable fixation.
Yes.
Smaller fragments is a indication, absolute indication for CVW. This may be a large fragment.
Yes.
Okay, right.
65 year female with intertrochanteric fracture of the left femur. It is body and griffin type 2 displaced. We have done close reduction and internal fixation. Yes.
Excellent exposure for
Yeah, yeah.
reticular pattern.
Sir.
Tell me different angles, yes, we got now. Which is Watt's triangle, which is Babcock's triangle. What's the importance here?
So the reticulate, name that reticulate.
Primaries and second. Two types of primary and two types of secondary.
Sorry, right. So, you,
Primary tension 1. పేర్లు గుర్తున్నాయి అంతే సార్ ప్యాటర్న్ తెలుసు సార్ దిస్ ఈస్ ప్రైమరీ సార్ దిస్ ఈస్ ప్రైమరీ ఫ్రమ్ హెడ్ ఆఫ్ ది ఫీమర్ టు ది గ్రేటర్ ట్రొకాంటర్ compression sir, primary compression. This is primary compression sir. From greater trochanter to the lesser trochanter it is primary tension.
two systems are seen here. One is tension typically, one is
Compression.
What are primary tension trigger?
Primary compression.
other side is compression.
Oscillary superior neck from the greater trochanter towards the head. That is what? That is tension trigger.
The primary system, second system also there. Other thing, can you make out your triangles here? Other triangles can make out.
What are the two triangles named in the proximal femur? What is its significance?
Watt's triangle, Babcock's triangle. So there.
రెండు ట్రయాంగిల్స్ ఏదో ఒకటి ఉంది ఏదో ఒకటి ఉంది
Where is Watt's triangle?
సొంత అదే ఇదే అదే
This is big one, what you're saying is Watt's triangle.
సార్
Interior part is saying Babcock's triangle. What's the importance of this? Leave Babcock, don't say Watt's triangle.
Chances of avian determine, yes, sir.
Base is interior part of the leg. This is the area from they used to think is only where they can get tuberculosis. This is from here. Leaders for tuberculosis starts from here. That's what they used to think. Now it's gone, but still you should know the triangles. Yeah, you should know about the triangles.
That is where the tuberculosis focus starts.
Focus.
Sir.
They should think. Nowadays you can't say that, but
Usually the knee joint, the synovial stage is the first. Next the articular. But in hip, it is not the synovium that gets infected first. It is the articular.
yes.
margins. That is the difference.
Sir.
Right.
Probably everybody must have seen, at least if not read, Tuli textbook. Have you
Tuli.
heard the name of
No.
Tuli?
Venoms.
Tuberculosis disease. Tuli.
Have you gone through it at any time?
ఇంకా
Never.
ఎగ్జామ్ పోయారు మీరు అవునా?
ఏముంది, అయిపోయింది. మళ్ళీ వార్డ్ ఆఫ్ అంటున్నారు
అవును.
next month నుంచి.
అప్పుడు అయిపోయింది వాడు ఇచ్చేసుకున్నాడు ఇచ్చేసుకున్నాడు
ఇచ్చేసారా?
ఇచ్చిందా వాడు అప్పుడు ఇచ్చిందా లేదా నువ్వు చెప్పు సార్ వద్దా అంటే వద్దా అవసరం లేదు రైట్
Okay, next. When do you allow him walking?
వస్తాం
When,
Well,
తెలుసుకోవాలి
మరి ఏం లాభం?
కదా, operation చేయటమే కాదు కదా.
చేసి పడేసి అయిపోయింది
Whether to make him bear weight or not.
Yes,
So how long?
After
అట్లీస్ట్
1.5 months, sir.
6
What is
weeks
the criteria?
Proper reduction and
Fixation.
callus formation.
Callus.
క్యాలెస్ అప్పుడు
Callus వచ్చేదాకా ఆగుతామా? Suppose if you
Toe
are a
touch.
40-year-old man,
టోటల్స్ కెన్ బి స్టార్టెడ్
the medial
48.
column, intactness of the medial column is the primary requisite for early weight bearing. Is it comminuted or not?
ఇట్ ఇస్
That is the first thing. Otherwise, there will be
Yeah.
varus collapse. Because the bone stock will be very poor in the elderly people in the head. And they get cut through.
Sir.
Premature weight bearing.
రైట్
Okay, next.
7-year child with closed proximal third, middle third junction shaft fracture of left femur, sir.
7 years
Yes.
ఇస్ ఇట్ నార్మల్ ఆర్ pathological is it
It's a trauma, sir.
huh?
History of trauma.
But what about the cortex? Penciling of cortex is there. Widened medullary cavity. It's normal. Other things, no other things are there. You can make out.
History of fractures anywhere else other than
చూసినావా?
No, sir. No.
But the cortices of the femur are very thin. 7 years ki. Kada?
the thin fellow? Moderate?
Moderate.
Moderate, sir. Moderate.
Heavy built.
Moderate. Moderate. Sir.
Okay.
Those X-ray is not a
అదే.
no soft tissue shadows at all.
We have done close reduction, internal fixation with TENS. Also.
Right.
No role for conservative management.
No.
You never think about.
What's age? 7 years.
7 years.
Till what age you want to apply SWICA? Start from 0 till 12 years. You have a choice now to treat conservatively. What age, what do you want to apply? Band fraction or the cross spinning or the spin, what you call TENS? What age?
Till 5 years.
At all age always choose only
It depends
TENS.
on the level of the fracture, first and foremost. Age, level of the fracture. Still it can be treated conservatively
Yes.
because it is in the junction of proximal and middle third. If you put him on very good quality of fixed traction in Thomas splint,
Or 19,
follow up,
99 traction. 9 traction, you know, 90 is easy.
or balance the
Yeah,
traction
99
under
traction is easy.
supervision.
Yeah.
You can avoid surgery in these people. seen so many complications with stents getting infected.
Yes, yes.
And the implant getting exposed proximal to the knee, infection,
Stiffness, lateral side,
prominent
Which is-
hardware, knee stiffness. We have seen so
Yeah,
many
yeah,
knee
right,
stiffness
right,
cases.
right.
Wherein they are not able to flex beyond 70, 80 degrees.
Sixty-three years male with closed intercondylar fracture of both femurs, sir, left and right. Yeah, this is a Eva Muller C2 type, sir. Complete interarticular.
Is it open fracture? No. It is not open.
Not open.
Close, sir,
fracture.
close.
Any,
C2, sir. We have done
what incision you made for this?
Sir?
2 incisions or 1 incision?
one incision, sir.
Where?
Midline, sir.
Midline.
Yes.
Anteromedial. Why midline? Anteromedial only. You can reach both sides.
Yes.
Hmm.
Sir,
Lateral?
medial.
Arthrotomy.
Arthromedial, sir.
Medial.
Medial, sir. Medial plate.
Was it off? No, it doesn't matter. Fixation, that's it. But you're going anteromedial, that has to go on medial side first.
Yes.
Then extend incision upwards and over lateral side you can go. That's what you have done.
Yes.
Yeah, if you are treating from lateral side first, anteromedial incision is there, directly go to fracture side. No, central incision is not good. Only thing is right hand. Only if anteromedial, that easily do.
33-year male with closed distal and
Okay, next.
33-year male with closed distal and radius fracture of the left wrist with the intraarticular extension, sir. It's volar button.
Ola bottom, is it?
Combination with
అది పోయింది కదా combination is still there.
articular surface is involved.
Is it die punch fracture? Could it be die punch also? How to make out die punch fracture?
Die punch, lunate involvement.
But only in CT scan you can make out, not in this there.
And
But I
there
don't think
is so much of displacement,
Yes.
comminution, and the volar fragment has got
Yeah, straight.
almost some 30 degrees angulation. Die punch, the architecture of the bone relatively remains intact, and it is a central
Depression.
in the lunate.
Done by lunate. Lunate was right. So what type?
Mechanism of injury is different. Okay.
Open reduction, internal fixation with plating was done. The radial height and radial inclination is maintained, and on lateral side the volar tilt is maintained in neutral position.
Why to go for ligament axis? Was it easy, no? Opening everything here will not be the best thing ligament axis should have done. Slightly reduce with a
Combination.
caver into the
Mm.
steroid process.
Another limited access.
Here I want to give the experience of one hand surgeon. He has come across a case wherein some 2 years back one fellow was operated for a volar bottom fracture by an Ellis plate, Ellis buttress plate. Okay, you know how is it different from this plate? Huh? The problem for which he presented to the hand surgeon is that he lost FHL, FPL, flexor pollicis long is not functioning. Flexors of the index and middle finger are not functioning, completely gone. And weak flexion of the little and ring fingers. What could have been the problem? And also the carpal tunnel syndrome. What could have been the complication?
So
What could have been the cause for this deficiency?
median of compression.
Hmm.
So at the flexor retina,
Okay, next what? Why did he lose the function of the flexors of the fingers.
Increased. Transverse
The
carpal ligament
buttress
pressure.
plate is not contoured for exactly for the distal articular margin for radial inclination. Sometimes they are almost horizontal, and it seems the plate was abutting or overlapping over the carpal bones. With each flexion of the wrist joint, flexion and extension, there is attrition of all these flexor tendons where they will pass through over the plate. Over a period of 2 years, the attrition has resulted in rupture of these flexor tendons of the thumb and index and middle fingers. That is an iatrogenic complication. So you should never try to allow the plate to go beyond the articular margin. And another lesson is, if at all there is a problem inadvertently noticed after surgery, the plate has to be removed as soon as possible, as soon as the fracture heals. Maybe after in 6 weeks it becomes sticky, maybe you can leave it for 3 months and remove it. In 3 months it is not going to cause much damage. It takes several months to years for the tendons to get attrition. This is a lesson to be learnt.
Yeah, but the approach you go also is important here. You want to go FCR approach or the true Henry's approach? Which one you want to choose to avoid these things?
Modified and this.
FCR approach, what? FCR. Flexor cap radialis. That approach is better rather than going to Henry's approach from there to here. So you avoid less complications with that. So you should know different approaches. There are so many approaches for the forearm and wrist. Which is good, which is bad, and what fractures you can use that. That you should know.
Brachyradial is good.
It's a very bad fracture, no doubt.
Right.
How do you rate the
Fracture.
fixation? Go back.
But
What will you look for rating the reduction?
We look for 4 parameters: radial height, radial inclination. In the AP view, we look for ulnar variance, radial height, and radial inclination. Radial inclination is maintained, radial height is maintained, sir, and there is restored, and ulnar variance is neutral, sir.
volar tilt is there.
Slightly negative.
Tilt is not there.
In lateral view, we will look for volar tilt, which is maintained in neutral. Neutral, sir. It is restored.
Not restored.
Not
Actually, it
restored.
is neutral, sir. Not complete volar tilt is
Not
present.
normal.
But the most important factor here is whether the articular congruity has been restored, whether the subchondral plate of bone has been restored to its normal.
Sir.
See that contour has been almost near normal, especially in the lateral view. See the subchondral plate throughout it is sclerotic.
Sir.
There is no deficiency. When do you want to mobilize this man?
6 weeks, 1.5 months.
1.5. You will come with a stick for this.
But comminution, it might
Comminution becomes sticky in 3 weeks.
1 month. There is chance of
Whatever you do,
refraction.
the chance of getting stiffness is there, but still you should know certain
Earlier
things.
the better.
Earlier the better.
And here the plate should have been a
Little more lateral.
not this design, variable angle. That will engage the radial styloid, which was not made use.
So
There are different
for,
designs of
for that reason they say lateral column, middle column, lateral column, medial column. We have column plates also. Right. Okay, done one, right.
So for the given fracture, it's a good quality reduction.
Sir. Styloid.
Styloid.
Intra-articular.
That's part of lower end. Right. Right.
Okay, all Barton's fractures, huh?
Today.
Volar batten, sir. AO B3, sir.
Okay, right.
We done open internal fixation plating, sir.
Mm. Right.
69 years old female with 3 weeks old intercapsular fracture of left femur, sir.
Right or left?
Left, sir.
Not right side.
No, sir.
Right, what do you have? Is it normal, right?
Rotate.
I don't think it's normal, right, also. Is it a metabolic disease fracture or what? Pathological fracture?
No, sir.
No, it's traumatic only.
Yes, sir.
Hmm?
Yes,
Not
sir.
stress one.
Sir?
Not a stress fracture or
No, sir.
following some disease, nothing.
She doesn't have any comorbidities.
But right side, if you take weight, you're not seeing. Right side, did you see what's wrong with right hip?
She
Hip.
is able to do SLRT on right side.
But taking
On-
weight?
Yes, sir. Before history of all, she was able to walk on her own.
Okay, now classify this fracture.
Subcapital types.
Subcapital? Okay. What? Trochanter?
It's an old injury. sir.
Old injury, yeah.
Yes, sir. She had
70
a
years.
yes, sir.
Mm.
She had a history of fall 5 years ago. She underwent massages and she was able to walk on her own.
Okay, next.
We have done cemented bipolar hemiarthroplasty.
Next.
45 years female with closed partial thickness tear of right ankles. Retrendaclis, sir. It is 2.5 centimeters away from the incision.
Partial thickness ante? Is it the area describing or the partial thickness
It's
diagnosis
actually
made
full.
clinically? Is clinical diagnosis made as partial thickness?
No, sir.
Hmm.
Clinically it was complete, sir. But in
What is rupture or not?
ruptures, sir. Complete ruptures.
Partial thickness is very. That surgery you want to see. Is it a incision?
The calcareous deposit has got avulsed almost
Yes.
Yes, sir.
away from the calcaneal tuberosity.
Yes, sir.
Partial thickness, I don't know what. Fraying of this thing, you have seen that. Those what is a partial thickness. Otherwise, avulsion only from the superior
That is
tuberosity.
second.
Yes.
Okay.
Sir? No, sir. Nothing, sir. Tear repair using Krakow's technique, sir, with buttons, sir.
Krakow, what is that suture you have done?
Sir?
Go back.
Suture.
Sorry, picture.
Pic-
Interrupt. Go back.
What is that?
That is after suture,
Yes, sir. Yes, sir.
not this one.
No, sir.
After next picture.
What is that gauze seen at this heel? What is it?
We have fixed with buttons, sir.
So what is it called now? What method you have done it?
Who is the one holding the link?
But
Jairam,
yeah.
sir.
Indena?
Jairam, sir.
Actually, it is in neutral position. In this position of the leg and foot, it should have been in 15 degrees of equinus, so that
Can make out.
the suture size will be put to minimum.
But what is that you have done coming up through the heel? What is this procedure called? How to anchor? Huh?
Anchored with buttons, sir.
But what is it called? I get what I know.
Window button,
No.
Window buttons.
What is it?
exo button. Button పెట్టినంత మాత్రాన button suturing కాదు అది.
Pull out suture, these are all.
Got a Bunnell's pull-out suture.
Buttons.
You might have put a back
But
use a Bunnell's
fixation is funnels only. You have sutured it.
through the tunnel in the calcaneum. It is called Bunnell's pull-out suture.
Right.
We should have been in equinus of at least 15 degrees in this position.
Re- With cast application, sir, with 10 degrees ebony cast, sir, with 6 weeks. Okay.
Rockwood green, 6 weeks, aboni with the 10 to 15 degrees of plant of flexion. Then 3 weeks, biloni with the plant of flexion. Then 3 weeks with footwear corrections. So 6, 3 plus 3, how much? 6 plus 6, 3 months. 6 weeks aboni, 3 weeks biloni, 3 weeks footwear. This is Rockwood green protocols. Campbell says 2 weeks, 2 weeks, 2 weeks. There is a difference. Campbell versus Rockwood green. Which is better? Campbell is better, Rockwood is better. Rockwood green is both better. Are good. Make average of both the things. Average. Equation. 1 plus 1 equals
partial.
b whole square equals a square plus b square 3ab.
Good morning, sir. Today's journal is Current Concepts in the Treatment of Giant Cell Tumor. This journal was taken from the Current Oncology, published on 8th April 2024, published by the
What is that?
multi.
Which journal is that? Journal. Which one? Is it pathology journal or oncology journal?
Oncology, sir.
Oncology journal.
Yes, sir. This journal was published by the Multidisciplinary Publishing Institute, Switzerland. Yes, sir. Introduction. Giant cell tumor is the one of the most benign tumor. Although it benign, it locally aggressive in nature and has malignant potential. Etiology is unclear. They have significant bone destruction, local recurrence, and occasional metastasis. Good morning, sir. Journal about current concepts in the treatment of giant cell tumors, sir. Giant cell tumor is the one of the most benign common bone tumor. Although it benign, it locally aggressive in nature and has malignant potential. Etiology is unclear. They have significant bone destruction and local recurrence and occasional metastasis. Contributes 5 to 10% of primary bone tumors, 20% of benign one. Affects mainly skeletally matured patient and maximum incidence is seen in the 3rd and 4th decade. Female to male ratio is 1.3 to 1.5:1. Malignant giant cell tumor is more common in males. The site of involvement usually solitary lesion and 1 to 2% of multicentric. Most common sites are distal femur, proximal tibia, distal radius, and rare in the small bones of hand and feet. The classification of giant cell tumor is Enneking staging and Campanacci radiographic grading and Jaffe et al. Pathological grading. Enneking staging, this staging is based on the biological nature of the tumor and extent of the tumor. In the stage 1, it is the latent benign or biologically static tumor. This is the X-ray of knee joint, AP view showing skeletally mature patient, and a lytic lesion is present in the proximal part of the tibia, and well demarcated margins are present, and there is no periosteal reactions in this stage 1. And stage 2 shows the active progressive growth limited by the natural barriers. Here the thinning of cortex is seen, sir. The lesion is intracompartmental only. Stage 3 is the local aggressive corresponding with the soft tissue mass. It is the cortical breakage was seen, sir, and lesion is extended into extracompartmentals. Campanacci grading, yes, grade 1 is the cystic lesion, grade 2 is the expansile lytic lesion with thin cortex but no break in the cortex. Grade 3 is the destructive radiolucent lesion with cortical break and soft tissue extension. The treatment of giant cell tumor for extremities, Campanacci stage 1 and 2, curettage, sir. Here the goal of curettage is the joint preservation and good function. Technique is the aggressive curettage with sharp curette or a high speed burr. Prevention of residual tumor by enlarge the cortical window to avoid the blind spot. Use intraoperative MRI endoscopy for the hidden tumor detection. After curettage, in extended curettage, adjuvants are used like chemical adjuvants, hydrogen peroxide, distilled water, alcohol, phenol. In thermal adjuvants, argon beam coagulator, electrocautery, and bone cement, liquid nitrogen, and cryoprobes. Here the depth of necrosis is argon beam and liquid nitrogen is 2.5 mm, cement is 0.8 mm, phenol 0.3 mm. 0.05% of chlorhexidine gluconate is most cytotoxic to the giant cell tumor cells. It is effective.
So liquid nitrogen is more effective.
Yes, sir, 2.5 mm necrosis.
complication of liquid nitrogen?
It affects the bone healing property and also healing of bone also.
So nowadays we are not using the liquid nitrogen, we are taking the ortho.
Yes, sir. The bone defect filling materials like bone cement and bone graft. In bone graft, freeze dried allograft, synthetic graft, and autologous graft. If cement is used near the joint, fill the subchondral bone with allograft tip bone first to prevent the articular cartilage damage, and consider plate fixation to prevent any fractures. Filling materials like bone cement is advantages of bone cement using is gives immediate structural support, early mobilization, and methyl monoacrylate monomer is the cytotoxic to the residual tumor cells. Recurrence can be easily detected on the radiographs. The disadvantages is it is not biological, weak in withstanding shear and torsional forces, degeneration of articular cartilage in subchondral lesion in weight bearing areas. The usage of bone graft advantages is it remodels along the stress lines and restores the bone stock, permanent reconstruction and biological reconstructions. Disadvantage of bone graft, difficult to differentiate the local recurrence and resorption. Less quantity if large defect, donor side morbidity, and allograft is expensive. Preoperative denosumab. If the usage of denosumab plus curettage is associated with the higher recurrence compared to the curettage alone. Mechanism of action of the denosumab, it causes the bone sclerosis and complicating the tumor removal and leaving the residual tumor cells. It does not induce the apoptosis of the giant tumor cells, especially in the H3F3A mutant types, leading to the tumor cell persistence. Evidence quality, some retrospective studies report no link to the recurrence, but bias exists as the denosumab was used in more aggressive cases. A randomized trial was inconclusive due to the poor enrollment. Follow-up recurettage is the possible after recurrence, and giant preservation was achieved in the 63% of such high-risk patients with good function. Musculoskeletal tumor severity score was 28, sir, out of 30. A risk factors for the local recurrence after the curettage. Tumor and articular surface distance is the less than 2 mm, posterior cortical bone destruction, and secondary aneurysmal bone cyst. Here the cause of recurrence is the increased bleeding, poor visibility, and incomplete curettage. The characteristic of the ABC is composed of the blood-filled cavities and fibrous wall. 30% are secondary, often arising from the giant cell tumor. And intraoperative or systemic factors like high preoperative mean arterial pressure predicts the recurrence only without tourniquet use. If the tourniquet use neutralizes this effect. And a high neutrophil to lymphocyte ratio also is high recurrence, and high prognostic nutritional index lower recurrence. Other inflammatory markers like platelet lymphocyte ratio, lymphocyte monocyte ratio, and alkaline phosphatase and lactate dehydrogenase is not consistently associated. En-bloc resection and reconstruction. En-bloc resection is the tumor is resected in as a single unit, sir, with along with margin of the tissue. The advantage of en-bloc resection is there is no leakage of tumor or residuals. Indication is the Campanacci stage 3B with large extraosseous lesions. Reconstruction options like for distal radius, wrist arthroplasty, osteoarticular grafts, prosthetic hemiarthroplasty. In arthroplasty, preserve the motion, but risk of subluxation, pain, and limited pronation and supination. In arthrodesis, ensure the stability, but sacrifice the mobility. In ulnar translocation, provide the strong and stable wrist with reduced complication. Donor side morbidity and high allograft fractures rates are the concerns. For proximal humerus, curettage has the high recurrence rate compared to the en-bloc resection. The functional outcome were similar with both en-bloc and the curettage. Reverse concepts, current concepts. Yes, sir. Reverse shoulder arthroplasty with allograft prosthetic composite is the preferred initial treatment in the Campanacci stage 3, especially when the deltoid and axillary nerve can be preserved. For pelvic giant cell tumor, curettage is the less invasive but high recurrence. En-bloc resection, lower recurrence but higher complications like infection, hematoma, and functional loss. En-bloc resection is preferred for tumors with large soft tissue mass and extensive cortical distension. Reconstruction with 3D printed prosthesis after the en-bloc resection showed no recurrence and the good osteointegration at the 3 months. For sacral giant cell tumor, here the risk of bowel and bladder and motor dysfunction due to the sacral nerve involvement. Preservation of the S3 nerve roots is essential for the bladder and bowel function. Curettage for tumors above the S3 and complete resection for tumors below the S3. The intraoperative blood loss is managed with the aortic balloon occlusion or embolization or short course denosumab. If the denosumab is given for greater than 3 months, may cause ossification and complicating the surgery and increasing the recurrence. Short course of denosumab, it gives the advantage of the comparable blood loss and shorter weight and less fibrosis. And non-surgical options like denosumab plus embolization used for the inoperable cases or where surgery risk is severe dysfunction. Outcome of the surgery group is the 44% recurrence, but 56% achieved continuous disease-free status. In non-surgical group, no progression, but 100% has the residual disease and lower functional complications. Giant cell tumor of the spine. A treatment depends on the Ennecking staging. For stage 2, treated with the curettage or subtotal resection. In stage 3, extracompartmental, treated with the total en-bloc spondylectomy. For this giant cell tumor of the spine, usage of the denosumab for less than 5 doses before en-bloc spondylectomy gives the advantage of the induced ossification and cortical integrity and reduce the tumor size and reduce the intraoperative bleeding. There is no tumor rupture or neurological deficit and no recurrence was observed in the 24 months of follow-up. Giant cell tumor with the lung metastasis. Incidence is seen in the 1 to 9% of cases. Management is the observation is recommended initially, especially with the small nodules, and larger nodules requires the close monitoring. Denosumab does not prevent the metastasis, can stabilize or halt the progression and reinitiated in inoperable cases or if surgery is declined. Metastatectomy reserved for the complication related to the denosumab. Alternatively, stereotactic body radiation therapy may be considered in non-surgical cases. Management is the individualized. Initial observation is safe for many. Surgical intervention should be weighed against the potential benefits and risks. Multicentric giant cell tumor affects the young individuals, rare and unpredictable disease course. The presentation usually asynchronous. A mean interval between the 2 lesions is 7 years. Synchronous lesions found in the 33% of cases. It commonly affects the knee and often occurs in the ipsilateral extremities. The treatment is primarily managed with curettage and requires continuous monitoring. Malignant giant cell tumor incidence is nearly 4%. Is the primary malignant and secondary malignant. At the time of giant cell tumor detection is the primary, and secondary is the malignancy develops after the surgery or the radiotherapy. Prognosis is 16% mortality seen in the primary malignant and 63% in the secondary malignants. Time of malignancy is the median age group is 15.2 years from the surgery to the malignancy. If the tumor enlargement during the denosumab therapy may indicate malignancy, prompt biopsy is recommended. Diagnosis is challenging by the imaging and requires biopsy, especially for the suspected transformation. For malignant tumors, localized disease, wide resection and chemotherapy, unclear benefit for the primary malignant, and improved survival in the secondary cases without metastasis. Advanced or metastatic diseases managed with the palliative chemo or radio and surgery. Denosumab monotherapy. The indication is the alternative to the surgery in unresectable or high-risk giant cell tumor cases. Here efficacy is the tumor regrowth occurs 40% in patient after stopping the therapy. Retreatment with denosumab is often effective. The monthly and 3-monthly schedule shows similar tumor control. Extended dosing is preferred to reduce the complication. The side effects of the denosumab: hypophosphatemia, jaw necrosis, anemia, hypercalcemia, and atypical femur fractures. Special consideration like denosumab contraindicated in pregnancy. It affects the fertility. As secukinumab may be safer and alternative drug. The comparison with the zoledronic acid, it is a similar efficacy, and denosumab has the fewer relapses but higher cost. Zoledronate is more hypocalcemia. Denosumab causes fatigue and back pain. Zoledronic acid has a higher recurrence, free survival at 4 years. Future directions: immune-based therapies and combination regimens are under investigations. Genomic profiling. Here the main mutation is the H3F3A gene mutation. Is a highly specific and common in giant cell tumor. It is rare in the histological mimics, useful in diagnostic marker. These gene mutants disrupt the chromatin structure, leads to the abnormal transcription and blocked mesenchymal differentiation. The targeted therapies may be promising for such cases. Conclusion is curettage is preferred for the campanology stage 1 and 2, especially in the extremities, pelvis, sacrum and spine without preoperative denosumab. Recurettage is the optional for local recurrence. En-bloc resection with 1 to 3 doses of the denosumab is used for the aggressive stage 3 tumors, and denosumab monotherapy every 3 months is standard for the inoperable or metastatic giant cell tumor, but tumor growth may indicate malignant transformation. Surgery remains the primary treatment for the malignant giant cell tumor.
Okay, good. So what is your conclusion? Say, review article.
Yes,
It's
sir.
a good one. I think, which year? I didn't see the year.
2024, sir, published.
24, okay. And this denosumab, what group of drugs are they? Do you know?
It is monoclonal antibody, sir. It acts on the rank ligand.
No, what group of drug is it? Zoledronic acid,
Bisphosphonate, sir.
bisphosphonate. It's primarily used for?
Osteoporosis, sir.
They're mainly for osteoporosis,
yes,
osteoblastic activity.
Yes. Yes, sir.
In the methods of treatment, what you have listed out, allografts were mentioned, no?
Yes, sir.
Huh?
Yes.
Allografts. And the distal end of the femur, custom megaprosthesis is not mentioned. That is one of the
Reconstruction, yes.
commonest site, and of the in a grade 3, that is the treatment.
Yes.
That is the most important point. What has been missed in the list of methods of management.
That's commonly practiced.
Yes.
See, the treatment of choice for GCT, of course, stage 1, is wide excision.
Yes, sir.
Wide excision means go through which tissue, normal or reactive?
Normal.
To normal tissue.
Tissues.
And especially it's very common tumor around the knee.
Around the nature.
So, prosthetic replacement. Previously we used to do, what is that? Reverse, this what's that? Reverse, rotation plasty. But now, because of the advent of modern orthoplasty,
Yes.
the treatment of choice would be an en-bloc excision, custom-made process, where the proximal femur, proximal tibia, distal femur. That's the treatment of choice. Yeah. Very. And bone cement, what happens is, most of the time, bone cement used as not as a permanent one.
Yes, sir.
Once tumor is maybe after 1 year, maybe 2 years, if there is no recurrence, we take the bone cement out and fill it with bone graft.
Yes.
The disadvantage, the main disadvantage of bone graft is recurrence. Difficult to differentiate between recurrence and this one. So, bone cement, we take it out, and especially young people, because these are young people. So, take it out and replace with a
Bone graft.
we have series. We have series of nearly more than 20 cases. 20 cases of GCT with custom made. And custom made, probably initial one, they do not last more than 10 years. So maybe 2-3 we revised again. Revised and used design. But modern custom made processes are very, longevity is more, so it's very near normal functional ability.
One more method of treatment, probably nobody is doing it now, Henneking's resection arthrodesis. We have done, it is not mentioned here. Not mentioned here. But the disadvantage is stiffening. Henneking's. They excise the distal end of the femur or the proximal tibia, bridge the gap with 2 fibular struts, and then fix it with a long intramedullary nail right from the greater trochanter to the distal tibia. They were available. They were not now probably. And fix with the 2 rush nails through the tibia to the through the fibular grafts into the distal stump of the femur.
Probably
But,
they
yeah.
have not mentioned
And
because
then
they said block excision and reconstruction. Reconstruction, I think probably
just to make it complete.
make it complete. They did not go into what is that reconstruction history and all those things. Okay, but it's a good article, and everybody 2024.
Yes, sir.
Anybody any questions, comments? Sridhar?
Gem. Near the articular cartilage.
Yes,
Near articular cartilage.
because if you put the cement on the articular surface directly, it will burn. Necrosis, cartilage necrosis. And if it is close to the neurovascular bundle also, it will cause thrombosis. Yeah.
Yes.
That's a new. Previously, it was not. I think this is a recent, popular recently. And especially inaccessible, where see around the knee, the treatment of choice would be en bloc excision, reconstruction, excision and reconstruction, which has got a very low recurrence rate.
Yes.
Yes, PPT is good. Presentation also is good.
Yeah, good.
Thank you.
For your spine cases and pelvic cases, denosumab is indicated.
Indicated, sir.
Restricted cases. You can go with the denosumab.
Yes.
That's recent
Route of
advance.
administration of denosumab, IV, IM, SC,
Subcutaneous.
what is the dose?
They're not given, sir.
You must.
Once in 3 months,
Those you should not remember. You should check the book every time
Yes.
because memory is not good for the dosage. Dosage you must check with the son.
Tumors. Double the dose. Yes.
Yeah, I think what very expensive, very expensive. The course is expensive because about 18 months to 2 years course.
Yes, sir. To avoid the complications.
So I think it's important. GCT is one of the common tumor and common topics for you, both in practice as well as exam. So you should be familiar, and probably you can. It's there anyway. PPT you can share.
Important for recent advances paper.
Yes, yeah.
All
That's
the things have been mentioned except custom made.
reconstruction is not mentioned. I think reconstruction.
Mentioned, sir, but only
Reconstruction
distal
not
radius
in
and
detail.
proximal humerus.
Not for reconstruction. Very good. Excellent.
Thanks.
Done? Anything else?
No,
All
sir.
done. Next,
Next journal.
On Sunday, there is a CME program in Gandhi Hospital on musculoskeletal infection. On Sunday. How many people? How many people got registered? Raise your hand. ఇంకా పంపే పద్ధతిలో ఉన్నారు. ఎంతమంది?
and this midterm meeting in August organized. Those are people requesting to organize midterm COSA meeting in CM. So one of the Saturdays, Sundays we can.
ఇది కూడా ఉంటుంది కదా మన OASIS.
Oasis. So can we combine two together? No. We can combine two together to a big way.
అంటే మిక్సర్ అండ్ CME should be elsewhere other than the venue of the OASIS.
No. Midterm Oasis as well as COSA. It should be different places.
I think name should be different.
So we'll do whichever bigger one.